Welcome back, dear viewers. Healthy mother, healthy baby. It's so easy to say, but do we really realize that this is the basis of a whole lot of problems that we have in obstetrics? Let's go and see how we can make this jargon, healthy mother and healthy baby, possible as we envision a healthy, thriving, prosperous future of the world. It should be with the knowledge that it is unattainable without a healthy mother and a healthy baby. Now, pregnancy and childbirth are considered amongst the most wondrous and joyous events in a woman's life, a joy that every mother is entitled to, but for a significant number of women around the world, each day it turns catastrophic. They end up losing their life. And let's look at this geography, that the maternal mortality ratio per lakh live births as of the statistics of 2015, India is somewhere in the middle. No doubt we have made progress, but there is a long way to go. So, if you look at it in a diagram here, the graph shows that we are on a downward trend, where the number of deaths and the mortality rates have been depicted. But my dear friends, the downward graph is still going very slow. We have to buck up. And the neonatal mortality rate is also down, but much more to go. Now, mortality rates, if you look at all these, the number of deaths and the mortality rates, you will also see that whilst we are making progress, there is still something more to be done. So, the maternal mortality rate in India for the periods of 2016 and 18 is 113 per 1 lakh live births. That is about 30,000 maternal deaths each year, and it is absolutely unacceptable. So, while the trend is low, when you start from 2004 to 2014-16, there has been a trend that is lowering from 254 to 130, but we still have to make progress. So, about 830 women die each day due to the complications in pregnancy and childbirth. This despite a 44% reduction in maternal deaths between 1990 and 2015. If you look at 1990 to 2015, certainly there is a reduction. Nobody denies that. But is that enough? The answer is no. Every day in 2017, approximately 810 women died from preventable causes related to pregnancy and childbirth. 11 deaths per minute. Isn't that horrendous? 94% of all maternal deaths occur in low and low middle income countries. Pregnancy and childbirth among leading causes of maternal mortality and morbidity in developing world. So, invariably their offsprings also bear the brunt. Each year, to see the statistics, 3.1 million newborns die within 28 days. 2.6 million stillbirths happen. 16 million newborns are low birth weight. 174 million under 5 are malnourished. Can we accept this? Because these are going to be the future citizens of our country, the future generation of our country. So, better beware, we need to change this. So, despite the progress over the last 2 decades, in 2018 alone, 6.2 million children and young adolescents under the age of 15 died. So, the interagency group for child and maternal mortality estimation have shown that even by the 1 to 11 months, 1 to 4 years and 5 to 14 years have shown you a devastating number of children that have died. So, if you were to look at health outcomes among women, children and adolescents are worse when people are marginalized, affected by discrimination, live in underserved communities in the most remote areas. So, in low and middle income group countries, up to 3 times more pregnancies among teenage girls. Why does that happen? Because they get married early and they produce babies early. So while they are mentally still not mature, physically their body takes the ravages of pregnancy. Up to 80% point difference in the proportion of births attended by skilled health personnel. At least 25% point difference in antenatal care coverage, at least 18% point gap care seeking rates, and 39% points higher stunting prevalence in children of mothers with no formal education. So, these statistics show that the most important determinant in improving women's health all over the world is wealth, and to ensure health and well-being of every woman, child and adolescent, we must build on what has worked in the past and use what we have learned to overcome existing and emerging challenges. How do we achieve this goal? Healthcare mothers and newborns can be provided the most effectively through an integrated continuum of care approach, which recognizes the close links between the health and the well-being of mothers, newborns and children. And how do we achieve this goal? We start much before pregnancy, adolescence and before pregnancy, and during pregnancy and during childbirth, the postnatal mother, then motherhood. So from the mother, then the postnatal newborn, the infancy and the childhood. So therefore, we need to have a full circle and not just look at the woman during pregnancy, because a healthy child is a healthy adolescent, is a healthy mother, becomes a healthy grandmother, and that is how we need to take this whole life cycle. So the pillars of continuing of care would be both from the government, the health facility, skilled birth assistants and community outreach providers. The network of safety of these 6 members of mothers network, who together have the ability to save her life and the life of the baby. Every woman, every child movement was launched in 2010 by the United Nations. It mobilized partnerships and coordinated efforts across sectors to ensure that all women, children and adolescents not only survive but also thrive to help transform the world. Building on progress achieved through the Every Woman, Every Child movement, the UN Secretary General launched in September 2015 an updated global strategy for women, child and adolescents' health to help further the Sustainable Development Goals. So, the global strategy for women's, child and adolescents' health, which is for the envision statement of 2016 to 2030, where they are looking for a global strategy. So, this would mean a roadmap to achieve the right to the highest attainable standard of health for all women, children and adolescents, to transform the future and ensure newborn mother and child only survives but thrives. And at a glance, our vision statement would be, by 2030, a world in which every woman, child and adolescent in every setting realizes their rights to physical and mental health and well-being, has social and economic opportunities and is able to participate fully in shaping prosperous and sustainable societies. So, the objectives and targets aligned with the sustainable developmental goals would be: 1. To survive, to end preventable deaths. So, if you were to look at all these points here, all of them come towards to survive in these kind of circumstances, to prevent deaths that can be preventable. The second one would be to thrive, which means to ensure the health and well-being. It's not only to survive but also to survive well, and that is to thrive. So, achieve universal health coverage including financial practices and occurs to the quality essential services and medicines and vaccines, and that would encompass the thrive portion. The next would be the transform, expand enabling environments. So, if you were to look at this, to enhance the global partnership to sustainable development, that means to bring about the world to be able to take the strengths of each country and to negate the weaknesses, thereby bringing about equitable partnerships so that all women, children and adolescents benefit. Now, reproductive, maternal, newborn, child and adolescent health, that is the RMNC plus A, is built upon the continuum of care concept and is holistic in design, encompassing all interventions aimed at reproductive, maternal, newborn, child and adolescent health under a broad umbrella, plus with focuses on inclusions of adolescence as a distinct life stage within the overall strategy. Pre-pregnancy interventions, well, very important. Pre-pregnancy risk detection and management, sexual and reproductive health information and services, contraception and birth spacing, screening and management of cervical and breast cancer, management of communicable and non-communicable diseases, screening and management of cervical and breast cancer, and gender-based violence prevention and response. Now, antenatal care, an overarching aim, and this is important to provide women with respectful, individualized, person-centric care at every contact, with implementation of effective clinical practices and provision of relevant and timely information and psychological and emotional support by practitioners with good clinical interpersonal skills with a well-functioning health system. Now, the antenatal care reduces maternal and perinatal morbidity and mortality, and both directly through detection and treatment of pregnancy related complications, and indirectly through the identification of women and girls at increased risk of developing complications during labor and delivery, thus ensuring referral to an appropriate level of care. Now, in addition, as indirect causes of maternal morbidity and mortality, such as HIV and malarial infections, contribute to approximately a quarter of maternal deaths and near misses. Antenatal care also provides an important opportunity to prevent and manage concurrent diseases through integrated service delivery. Now, the components of antenatal care is risk identification, prevention and management of pregnancy related or concurrent diseases, and health education and health promotion. So, we have antenatal care, which are two models, whether it is the WHO FANC model or the WHO ANC model. The difference here would be that if you were to have the FNAC model, it would be the 8 to 12 weeks contact in the first trimester, or the contact in the ANC would be up to 12 weeks. The second trimester would give you a contact in the ANC at 20 weeks and then at 26 weeks, and in the third trimester the ANC model WHO will give you a contact at 30, 34, 36, 38 and 40 weeks, whereas in the FNAC model it will give you at 32 weeks and then at 36 to 38 weeks. Return for delivery at 41 weeks if not given birth by then. Now, if you look at the word contact has been used instead of visit, because a visit implies an active connection between the pregnant woman and a healthcare provider. The schedule of 8 contacts outlined in the 2016 WHO ANC recommendations is intended to be adapted to national and regional context when it is adopted at country level. So, At the third trimester context, the ANC providers should aim to reduce preventable morbidity and mortality through systematic monitoring of maternal and fetal well-being, particularly in relation to hypertensive disorders and other complications that may be symptomatic but detectable during this critical period. So, quality of antenatal care will tell you to encourage women to seek skilled care at childbirth, reduce stillbirths, help women get care and counseling. So, quality antenatal care should be available for all women to ensure a positive pregnancy experience. So, ANC includes, that is, the antenatal care includes nutritional interventions, maternal and fetal assessments, prevention measures and interventions for common physiological symptoms. So, what about the labor and delivery care? All women have a right to a positive childbirth experience. That of course includes respect and dignity, and going through this childbirth must be a very pleasant experience, reducing the mortality and the morbidity and the birth position, as well as all the choices that the woman can actually have, provided it is safe for her to deliver in that kind of position. Essential physical resources would include respect for labor and childbirth care, emotional support from a companion of choice, effective communication by staff, pain relief strategies, regular labor monitoring, documentation, audit and feedback, oral fluid and food intake, mobility in labor and childbirth positions of choice, pre-established referral plans and continuity of care. Postnatal care. Most maternal and infant deaths occur in the first month after birth. Almost half of the postnatal maternal deaths occur within the first 24 hours and 66% occur during the first week. So, the postnatal care highlights should be able to provide active care during the first 24 hours after every birth, and then daily facilities should be given to these patients every 24 hours till approximately a week, and then there can be home monitoring by the local health workers so that the care is given for the first month. This will take care of the neonatal period as well as the perinatal period and also look after the mother. So, single term postnatal should be used for all issues pertaining to the mother and the baby after birth and up to 6 weeks, that is 42 days. Most maternal and infant deaths occur in the first month after birth. Almost half of postnatal maternal deaths occur within the first 24 hours, and 66% occur during the first week. What is the newest gadget in India's arsenal in the battle for healthy mother and healthy baby? We have the Surakshit Matritva Ashwan, that is Suman, an initiative for zero preventable maternal and newborn deaths, which is a combination of what I have been speaking to you. Union Health and Family Welfare Minister Dr. Harshvardhan launched the Suman scheme along with other state health ministers on October 10, 2019 during the 13th conference of Central Council of Health and Family Welfare in Delhi. What it does is it aims to assure dignified and respectful delivery of quality healthcare services at no cost and zero tolerance for denial of services to any woman and newborn visiting a public health facility in order to end all preventable maternal and newborn deaths and morbidities and provide a positive birthing experience. The service guarantee would be zero tolerance to any negligence, integrates existing initiatives, respects for women autonomy, dignity, feelings and choices, 100% maternal death reporting and reviews, grievance redressal mechanisms, client feedback mechanisms, awards to champions, community level maternal death reporting, community engagement and mega IEC and BCCs, intersectoral convergence. Suman also provides provision of at least 4 antenatal checkups and 6 HBNC visits, that is the health birth visits. It also assures early initiation and support for breastfeeding, 0 dose vaccinations and management of sick neonates and infants. Safe motherhood booklets and mother and child protection cards are given, respectful care for privacy and dignity, free transport from home to health institutions, time-bound redressal of grievances through a response call center and postpartum family planning counseling. Deliveries by trained personnel, choice for delayed cord clamping beyond 5 minutes and assured referral services with the scope of reaching health facility within 1 hour of any critical case emergency, birth registration certificates from healthcare facilities and counseling and information, education and counseling for state counseling and IEC for safe motherhood. Free and 0 expense access for identification and management of maternal complications, elimination of mother to child transmission of HIV, HPV and syphilis, drop back from institution to home after due discharge and conditional cash transfers, direct benefit transfer under the various schemes. In the words of Amina Mohammed, who is the United Nations Secretary General's Special Advisor, by investing in a woman, child and adolescent today and over the next 15 years, we can save a generation within a generation while benefiting many more to come, but the opportunity and responsibility to act belongs to us now. So, a woman is the full circle, within her is the power to create, nurture and transform. Thank you very much.